there's part of what you're saying that registers that maybe our response to COVID-19 has been exaggerated, overblown, that many cases are mild, and there was sort of some fear mongering and maybe some panic. Is that a fair characterization of what of how you're thinking about this?
It's a little too unkind in some ways, and the reason it's too unkind is that early on the data is poor. And people are trying to make the decisions in the face of poor data. You see, the really fun part behind it, Peter, is studying how human beings respond to risk. The topic's been examined. There are a number of good textbooks around it, for example. Turns out that this is all part of quality improvement, just in passing. The human mind, subconsciously, is not good at assessing risks, rates. We're no good at rates. We're wonderful pattern matchers, but when we ask people to assess rates, probabilities, right, we're absolute crap.
Yeah.
I don't care how smart you are, how well trained you are. I've got, I think, as much experience as anybody at this, and I'm still crap at it, and I've never met anybody who isn't. So it all depends on those data, and what it does is it changes our risk perceptions. But good leadership has to look at the whole picture and balance the risks back and forth. We've had some people in the space who, when challenged on this, have basically said, hey, my only assignment is COVID. I'm going to focus exclusively on COVID. And what I'll tell you, I do mean this as a criticism. When I see somebody say that, I realize they're saying, don't look at me as a leader. I'm not going to position myself as a leader in the area. I think you have to see the whole picture, not just one little teeny part of the picture. Well, one big part of the picture. It's not that teeny, is it? So if you see what I mean, but you need to see the whole picture.
Well, at the risk of putting you on the spot, do you care to name a name? Because I know a couple floated into my mind as you were talking about people who said, my job is to focus only on COVID.
Yeah.
Are you specifically faulting Dr. Fauci here?
You be the judge. It's a number of different people in leadership roles who need to see the whole picture. You know, it's because at my age, I get to be a bit of a curmudgeon, but it's a combination of two things: surgical triage. In talking to some of our young folks in the profession, I sometimes wonder if we've done a good enough job of teaching them about hard trade-offs when they occur. Back in the old days, when I was doing surgery, you were sometimes forced into those trade-offs. How do you best make them? You see, when time is of the essence, you don't get a lot of time to sit and cogitate and have debates. And number two, this idea of proportional hazards. The way I say it to my students in my classes, so we saved you from COVID. COVID didn't kill you. Does that mean you're going to live forever?
Of course not.
Of course not. Yeah. So it's that idea, and when people look at it that way, that's exactly what they say. They say, of course not. And what you're really saying when you say that is, I have to have a balanced approach. Cancer is still a second most common killer in the United States. Ischemic heart disease. Deaths from ischemic heart disease this year will totally overshadow COVID deaths. Now, we haven't lost the whole show, of course, but you know, we need to keep our focus on the whole picture.
In terms of the missing care for cancer and heart disease,
yeah,
we don't know how that's going to play out in terms of morbidity and mortality. And actually, might we be conducting a natural experiment that some of that care that we were delivering was inappropriate and not necessary, and that we may not see a rise in cardiovascular disease, morbidity, and mortality, and we may not see a problem with people's missing cancer treatment. I mean, that's another possible outcome here, correct?
Well, so yes, it's a possible. And I was going to say touche because I'm one of the guys going around saying that we have too much inappropriate care in the system, and I get that.
Right, right.
You're calling me on my own past here.
Yeah,
Sort
15 to
about there.
20%, I think you said, right?
Yes, I do. Interestingly, almost certainly our heart disease mortality rates are up. We have early data. It's early data. It'll show up better later. I was talking to John Perlin, he runs chief medical officer for Columbia HCA. He runs a major EMS service. An early indicator, what he told me is he said in those EMS teams are called to people's homes on a 9/11 call. He said the proportion of times that they find a patient who is already deceased or moribund, not recoverable, he says he thought was up about 50%. So the theory says it should go this way, well established. I mean, it's not just through long experience. And sure enough, the early data we're getting are showing that it is. So I would be, let's just say it would be miracle class if it doesn't. Could happen. We'll find out when we get the data. But so far, the early data is matching the expected experience with a really sound basis for having that expectation, is the way that I'd say it. So yeah, there'll be a secondary price to pay. The other question I like to ask my students, so is it somehow innately worse to die from COVID than to die from another cause? What I'm actually playing games with here, Peter, is humans' perception of risk, how we respond to risk. And we tend to focus on one risk and we get monofocused and we tend to lose track. And by the way, this is part of the human condition that's been going on forever. I don't know if you've been tracking the international news relative to starvation. Because of breakdown in economies, people pushed into starvation. The numbers the World Health Organization is sharing, the breakdown in our malaria, tuberculosis, and HIV treatment and management systems. And what I'm seeing from those data, I'm not an expert on it, but I'm seeing estimates that suggest that the mortality impact from breakdown in those systems could completely overshadow the COVID impact. We'll see, right? And now, don't get me wrong. I'm not saying COVID's not important. It is. All right. I'm just saying you gotta, sorry, but you gotta keep your eye on the whole picture, is what I'm really saying.
And you're saying we failed to do that. We have failed to do that. We have failed to do that.
Well, we're human beings, and humans by definition are imperfect, but we haven't done it as well as we could, in my opinion, not just in the United States, but worldwide. And it's a fascinating topic to look at why humans react that way. It seems to be hardwired in our evolutionary brain to some degree. So I've got you properly distracted, Peter, way off on this sidetrack here.
No, it's
a fun one.
It's an important one, and I'm glad we're discussing it.
But here's the point: in about a year, we'll be on top of this thing. I mean, we're already starting to get on top of it, but in another year, at least here in the United States, we'll be pretty much on top of it. It'll be with us forever, by the way, just like influenza is with us forever, right? It'll be just part of our panoply of infectious diseases that we always worry about, but we'll have effective agents, effective treatments. We won't have a virgin population that's so highly susceptible to a new novel virus that spreads rapidly and widely. But it'll be in our rearview mirror. Why is that important? So the story, I was talking to one of my fellows, my students really, who graduated from our clinical training programs, Dr. Pierre Chapard and Pascal Briot is his number two. They help run quality at the hospital of the University of Geneva, in Geneva, Switzerland. Pretty good health system, by the way, and they've been doing some beautiful quality work. They were commenting to me that relative to COVID, it was new, it was novel, how open the professional teams were to change. And it was just beautiful examples of rapid clinical change as we explored this disease, understood it. People were actively seeking treatment guidance. It was evolving at a very rapid rate. So the very best that you'll ever see in quality improvement. Well, what happened is they started to get on top of it, and then they shifted back to some of the existing issues they had with the rest of care, with the other elements of care where they really wanted to drive some change. And they were hoping that with the COVID response that people had kind of broken loose and they'd be open. What they tell me, at least in that circumstance, is they were amazed at how fast people locked back down, and they were right back where they were when they started. Now that was disappointing. You're hoping that it would break everything loose for real long-term change. So that was one of my real hopes. You know, again, to an old cliche, never waste a good crisis.
Right.
But could we use the crisis to break people free and accelerate the rate of change for things that we know are important in the quality space? You see, that's what I was looking for. And at least Dr. Chopard's initial report is you're still going to have to go fight the good fight, Brent.